We'll move on now as we go through the hour to talk about quality of life and patient perspectives in PAH. The Sixth World Symposium created a task force that highlighted the importance of patients' perspectives, with input from patients directly, of course. Despite recent progress in patients' involvement in the PAH field, patient surveys indicate that more can be done to improve this aspect. So some of the key recommendations were that the importance of patients' perspective has been outlined by this task force, and because more can be done, patients should be provided with access to expert centers that provide a multidisciplinary approach, including shared decision-making and participation in education. In order to advance the role of patients, the World Symposium recommended empowerment and engagement for patients in all aspects of their experience with their PAH journey, and to cultivate the importance of health-related quality of life in the care of PAH patients. Dr. Humbert, can you give us a little bit of an overview about the goals, compare and contrast the goals between patients and practitioners? Obviously, we as practitioners are interested in the science and outcomes that are hard outcomes, and we're appreciative of patient perspectives, but maybe don't give it the appropriate addressing in clinical trials.
Yeah, thank you, Ron. Indeed, we should never forget the patient perspective. At the end of the day, this is the key goal of our management. And we, as you said, we have to align our goals with the patient's goals, and it should be the same at the end of the day. So I think the Sixth World Symposium on Pulmonary Hypertension was really good in putting together a specific task force for patients and for quality of life and patients' perspective. So clearly, we need the patients in all our multidisciplinary approaches. And now when we build guidelines, statements, etc., we always try to have the patient's vision and their empowerment in the decision making. Of course, we have to reduce the functional burden. We have to reduce the psychosocial impact. The patients, they should have a normal or near normal life whenever possible. And the therapies themselves can be burdensome sometimes, and hospitalization should be really prevented. On the other hand, the doctors, they express that in a different way. But when they say symptomatic improvement, functional improvement, delay in disease progression, extend life expectancy, stabilize right ventricular function, in fact, it mirrors, it is mirroring the patient's perspective, but it is not said with the same words. So it is really critical to recognize when there is a difference in perspective in order to improve the partnership between healthcare providers and patients.
Absolutely. Can you provide an overview of the health-related quality of life tools available for PAH patients, particularly what you're using at your center?
Yeah, no, it's really important to highlight the fact that we have quite a lot of instruments to measure quality of life. These instruments have been used mostly in controlled trials and not commonly in daily practice. And this is something we have to work on. Of course, we always try to analyze the functional class, but it is a very broad appreciation of the patient's functioning. But in fact, we now have generic quality of life tools like the SF36 with many items, the EQ5D with even more items, and others which are less time consuming. But what is really difficult with the generic quality of life questionnaire is that sometimes they miss the specific point of PAH patients. So our community, doctors, social workers, nurses, patients have created patient-oriented or PAH-specific quality of life instrument, such as CAM4, PAH SYMPACT, or UNPhases 10. What is really important is that these instruments should be easy to complete. It should not be one more burden to the patient. It should be easy to interpret in the clinic, and it should be a good reflection of the status of the patient and the future outcomes. So the beautiful recent achievements have been to put in perspective quality of life instruments with future outcomes in large US, UK, European registries. In my center, currently we use mostly the PAH specific instruments, but mostly in controlled trials. And in the French registry, the quality of life instruments are not mandated, which is certainly a limitation.
Yes. Dr. Ivy, in Colorado, are you using any of these instruments, and how do you, where's the hierarchy of quality of life in your management of your patients?
I think we use the PEDS QL tool. I think that we probably don't do as much of this as we should. I think we do it by discussions with the family, and I think the goals are similar, but sometimes the specifics may be a little different. So for children, I think two of the main things that we ask about are how many days of school have you missed, and are you able to go out on the playground or do some other activities with your friends? How far can you walk if you go to the mall, those kind of things. But I would say in terms of routinely using these type of measures, we don't use them as much as we should.
We're guilty of the same. Dr. Humbert, what is the role of quality of life scores in prognostication and risk stratification?
Well, it's a key question indeed. Does it add anything on top of what we currently measure as doctors in our daily practice? So clearly there have been recent important articles published both in the European Respiratory Journal and in the American Journal of Respiratory and Critical Care Medicine, showing that having a measure of quality of life adds information on top of the currently validated risk stratification tools. So ANCC 10 is a rather simple pH-specific instrument, and Dr. Lewis and colleagues have recently published in the European Respiratory Journal some good data showing correlations between ANCC 10 and exercise capacity, functional class, and also measures of walk distance, and there was also some information indicating that there is a relationship with mortality. So the worse you feel, especially with these disease-specific instruments, the more likely you have a more advanced disease with more consequences on your daily life and future outcomes.
And using this instrument, the impact of COVID-19 was looked at. What did the findings show there?
Well, COVID-19 has been, of course, dramatic everywhere around the world. And when you were affected with PAH, you had to shield yourself, to stay home and hope for good. I mean, it was very difficult to have access to a specialized clinic, at least in my country and in many. We developed, of course, telemedicine. We kept a contact with the patient and their families. But the good news is that there is good news and bad news, of course. The good news is that the patients, although they felt isolated and more lonely, they did not change much their quality of life feeling. But on the other hand, I can share with you that during the first two waves, at least in Europe, the patients who were infected with SARS-CoV-2 had a quite high rate of mortality. So on one hand, COVID was a threat. It was a universal threat. The patients tried to avoid the virus. When they were infected, the outcome was not good in many. But in terms of quality of life, I mean, they stayed more or less stable. The worst scenarios remained bad, and those who had a reasonable quality of life coped with the acute COVID crisis.
Dr. Ivy, has the pediatric population been looked at in terms of the impact of COVID on the PAH patients?
Yes, but there are very, very few patients. Dr. Oudiz at Texas Children's Hospital looked at a group of PH patients, and she showed that the Hispanic population was more susceptible to dying with COVID. The other group that seems to be affected is those with congenital heart disease in one study published this year. We don't have as much data, but for me, the patients that particularly seem at risk are those with syndromes such as Down syndrome, who are obese and have obstructive sleep apnea and other comorbidities. We've seen several deaths in that group of patients.
Now, there is a large registry that's growing every day called the PAH registry, or FAR. And in one of the analyses looking at the outcomes of patients with risk scores that were assigned either using the Compara registry, mainly out of Germany, or the Reveal US registry, there are some data that suggest that regardless of whether or not you use Compara or Reveal, you can predict hospitalization based on quality of life markers. And so, Dr. Humbert, is this something that can be maybe extrapolated and looked at, looking at the registry outcomes using the French low-risk stratification?
Yeah, thank you for this point. Indeed, we both with Dunbar shared the guilt that we don't use enough the quality of life questionnaire, sometimes also because they are not that easy to use in daily practice, and some quality of life instruments are easier, like on phases 10. As you say, the Pulmonary Hypertension Association Registry produced excellent data recently. One thing which is important also is that the comorbidities affect the quality of life, and you may have, PAH plus obesity, and your quality of life measure will be affected because of the comorbidities, and it will translate into more severe quality of life measure. But on the other hand, the very interesting data is the added value on top of the current restratification instruments. And it is certainly very promising, and thanks to this data from PHRR, we certainly have to consider adding the patient's perspective in our multi-component restratification instruments.
Dr. Humbert, can you comment on a study that looked at the psychosocial support in patients with PAH and how their treatment adherence relates to that?
Yeah, so we have some data published on quality of life, treatment adherence, and psychosocial support in patients with PAH. And this paper has been published by Dr. Iverson and colleagues. The patients in that study had either PAH or CTEPH, and the patients with PAH were obviously younger than the patients with CTEPH, and the patients with a lower quality of life measure, they had more concerns about treatment, lower coping ability, less emotional support, and less accessible social network. So altogether, impaired health-related quality of life can reflect a lot of components we don't always measure in our clinic when we do a walk distance, a BNP measure, and a right cast. So I think these kind of data are really informative for our practice.
Great. One last question before we start to wrap up. Home-based exercise programs have been shown to be effective, and you can implement them at least in concept. And I know that many years ago we looked at outcomes that have been potentially changed by exercise, first starting with the hospital-based and then later with the home-based. But I'm not sure if we have data, a lot of data on how that affects quality of life, either in the pediatric or the adult population.
Yeah, it is important. I mean, exercise, of course, always a word of caution, should be supervised somehow, and the medical team and the nursing team has to be, of course, involved in the assessment of the patient capability to exercise, especially at home remotely. That being said, we have now more data showing that exercising, when possible, translates into better quality of life. And this is certainly one approach we have to consider seriously in these patients. I don't know if in pediatrics you do home-based exercise rehabilitation or kind of, I don't know, Dunbar.
Well, we, not as a formal program, what we usually do in our functional class 1, 2, and 3 patients is do a cardiopulmonary exercise test to be sure that, as best as we can tell, that it's safe for them to do some exercise. And then we just are very, very strict about talking to the patients about limiting exercise, and but we want to be sure that they're not at risk when they exercise. And we do promote home exercise or some light sport, but again, as you said, we're very cautious to be sure that our severe patients are supervised, and for us, in some ways, it may be easier because we say then a parent needs to be with you when you're doing these either regular walks or bicycling or some light sport.
Well, let's just summarize this second section in our hour today. The assessment of objective measurement of cardiopulmonary status has helped us achieve better clinical outcomes for patients and to develop new therapies, of course, through to the point of market access. However, patient surveys indicate that more can be done, obviously, to improve holistic care and patient engagement in clinical trial design, in clinical trial participation, and in assessment of outcomes. The clinical teams that we all embrace in our centers need to acknowledge and embrace the individual patient's perspective, and thus improve the care for the individual patients suffering from PH by cultivating the importance and relevance of health-related quality of life in direct clinical care. At the patient individual level, patients should be provided with access to accredited specialist centers which provide a multidisciplinary approach where there's a culture focused on narrative medicine, quality of life, shared decision-making, and timely access to palliative care, and where there's participation in education. On a larger scale, there's a need for development, expansion, and promotion of patient associations like PHA to support them and their caregivers to lobby for access to best care and treatments and provide input into the development of clinical trials and registries, focusing on the patient's perspective.